Welcome to Stories of Safety. In this podcast series, we will talk to the people who have shaped healthcare safety. We will explore the stories, science and policy that have shaped how we think about, manage and measure the safety of healthcare. This series is funded by the National Institute for Healthcare Research and brought to you by the Patient Safety Research Collaboration in Yorkshire and Humber. I'm Jane O'Hara. I've been a patient safety researcher for over 15 years. In this time, I've come to understand how complex healthcare is and how difficult it can be to answer one seemingly simple question. How safe are we and how can we improve? In this series, we will be exploring this deceptively simple question from all angles, with people who have helped shape healthcare safety in the UK and across the world. In this episode, we are exploring how incident investigation came to be the cornerstone of efforts to manage and improve safety, and what its role was in shaping the early patient safety movement. And who better to talk about this but the great Charles Vincent. Say hello, Charles.
Hello, Jane. A pleasure to be here.
Okay, so a little bit of background on Charles for the uninitiated, although I can't imagine there's many of those. Charles originally trained as a clinical psychologist and worked for the NHS for several years before undertaking a PhD at University College London. This PhD kicked off an extraordinary career in patient safety. Over the last 4 decades, Charles has conducted research on the causes of harm to patients, the consequences for patients and staff, and methods of improving the safety of healthcare. He has been part of many important and consequential inquiries and committees, including the Bristol Inquiry, the Parliamentary Health Select Committee, the Francis Inquiry, and the Berwick Review. His Google Scholar page tells me that Charles has published over 660 scientific articles and books and has been cited over 50,000 times, which for the non-academic listeners is an incredible number, an incredible legacy there, Charles. You should be rightly proud. So put simply, Charles is the OG patient safety academic in the UK and is one of my safety heroes. So it's really brilliant to have you here with us today, Charles. Thank you so much for joining us.
Well, thank you, Jane, for these very kind remarks, which I could challenge, but won't, in the spirit of keeping things on the road.
Well, you can't challenge because it's there in black and white, 50,000 citations. It's something that I can only dream of, Charles. So at the beginning of these podcasts, I like to get a bit of a sense of place. So where were you born, Charles? Tell us something interesting about the place where you were born.
I don't think there's anything interesting about it. I was born in the suburbs of London and grew up there in a very ordinary environment. And so I think I can't think of anything interesting about it at all. That's the most interesting thing.
That there's nothing interesting about it. Well, luckily for you, I went on to Wikipedia to see if you had a page. And I was shocked to find that you don't actually have a page. But I did find, by strange coincidence, a doppelganger, Charles Vincent, with a portentous link to patient safety. So Charles Vincent was born in 1823. He was an actor, but working in Australia. And in 1868, he died when an apparently innocuous injury turned septic. But the really interesting thing, Charles, is he was married to an actress, just like your good self.
Now, that is interesting. Well, I can tell you also about the third Charles Vincent, which was my great-grandfather, I think, who was a composer and musician. I have a cigarette case presented to him, a silver cigarette case, on the occasion of the premiere of an opera he wrote called The Wreck of the Hesperus. I wish I had his musical talent. It was amazing. It came to many members of my family, but not me.
And do you listen to his music?
No, we have done. There's still little bits available.
Oh, fantastic. What a lovely anecdote. Thank you very much for sharing that. So, unlike Charles Vincent, the actor, you trained originally as a clinical psychologist.
Yeah.
How did you, and why did you start getting interested in patient safety research?
Well, after I was a nursing assistant for a year, and then after the clinical psychology, I worked in the NHS for a bit, and I did all sorts of things. I had a very sort of feckless early career, I think it's fair to say. And eventually I ended up trying to do a PhD in part-time on a totally unrelated subtopic. And I had lots of different jobs trying to support myself, and it was just very, very difficult. And I needed a job in the psychology department where I was doing the thesis. And I got a job with a man called Professor Bob Audley. He's a very lovely man who gave me a job on a project called Avoidable Mishaps in Medicine in 1985. And I worked on that for a year, and then we got some more money in another couple of years. It was funded by the Medical Protection Society, who were very forward-looking at that then and maybe now in funding research on really why they were paying out this money, why patients were harmed. You know, they were interested in more than litigation. Obviously, at that time, 85, the polite term avoidable mishaps was a polite term for the things that people knew were happening, but nobody had any idea of the scale or the impact on patients or anything. It was the very first foray into what became later patient safety.
And interesting, your personal tale there of how you got into academia. I always describe myself as an accidental academic almost, because it was never particularly planned. So it's good to know that I'm not alone, and that somebody with your legacy has had a similar start in life. So
yeah, I had when I was training as a psychologist, I had no plan at all or interest in being an academic.
And really interesting as well, I think, how people's careers get shaped by the people that they work with as well. Like you, I was a psychologist and didn't have any plans to go into patient safety, met Rebecca Lawton, and the rest is history, really. And it's all kind of stemmed from there. So moving forward then, from that early work that you were doing, I know that there was sort of national and international conversations that were starting about patient safety and the need to understand the scale of the sort of burden of incidents, and that some of these discussions were happening internationally with people like James Reason. I believe there was a meeting in America that happened around in the sort of mid to late 90s. Were you part of those discussions, Charles?
Perhaps the best thing is that I just sketch out over a few years what I did and what I knew. And I suppose until about 1990, it seemed like we were working in this area. I had no colleagues, if you like. I had colleagues at UCL, but I didn't really know anyone else who was doing anything like this. And indeed, it was, or rather odd, it didn't matter very much at that time. But around 1990, I became aware, I think I heard about the Harvard Medical Practice Study. It wasn't published. And I got sent I contacted Russell Acalio in the US, and he sent me a giant book summarizing the Harvard Medical Practice Study, which showed a very large number of patients were being harmed in the United States. And later, indirectly, this led to me and colleagues, Graham Neal and Maria Voloshinovich, doing a study in Britain and finding that 10% of patients are harmed. We published that in 2001, I think, and the review was done about 1998. So over that sort of 10 years, the 1990s, gradually we became aware. We started to have instant reporting in Britain, so in a serious manner, about 1995, and I edited a clinical risk management. It was published in 1995 by the BMJ, which the risk managers called it the Bible, because there wasn't anything else. And, lots of people generously wrote chapters to bring this book together. And I remember sort of sitting there with a blank piece of paper thinking, what is clinical risk management? What's going to be in this book? And we had published a previous book called Medical Accidents in 1993, which was the beginnings of this sort of way of thinking, and both that and both those books had this two directions, really. They had clinical topics where expert clinicians wrote about the challenges of keeping patients safe in surgery or maternity or whatever it might be. And then we had what you might call thematic issues, like team working and learning from instance, some thematic issues on the sort of factors that promote or degrade safety, and some on the actual safety processes themselves. And obviously that continues to this day. I don't mean that was my idea, but I mean that was the way we were all thinking, those of us involved in it. And the incident reporting and analysis was a particular part of that, as you mentioned, which I guess we'll come on to.
So it sounds like you were in the right place at the right time, in a sense, that you were starting to do this work at a time when others were looking around and trying to connect with people who were also doing this work, and the sort of research and practice community grew. Is that fair to say?
I think when I started, and for quite a long time, there was really nobody. I mean, I think later became aware of other people doing similar things. And I think they had the same experience of people working in isolation. Lucian Leap certainly was in a similar position, writing around the same time as me, going to libraries and trying to look up medical error and finding nothing. He talks about going to the Harvard Medical Library and asking what they had on medical error. And they said, well, absolutely nothing, but there's a huge section over there on aviation you might like to look at. And I didn't meet Lucian until much later. So yes, there wasn't a sort of community at that time.
So how did it emerge as a sort of patient safety movement within the UK, in your view?
I think it emerged differently in different countries, and certainly in the United States, patient safety emerged as sort of a clinical issue that was largely separate from the management of risk in the sense of worrying about litigation, although some of the litigation companies and organisations funded safety research. I think in Britain, to begin with, it was much more concerned with litigation. And the Medical Protection Society funded our work, I think, partly out of a worry about litigation and partly, quite genuinely, partly on a concern for patients. But it was driven, if you like, by the mounting litigation or anxieties about litigation, I think it's fairer to say, because I think they've often been hugely exaggerated. I mean, it's a very unpleasant, horrible experience for doctors or nurses to be involved in it. We could talk about this, but the idea of risk management early on, if you like, was partly to do with, if we knew earlier about these incidents rather than years later, we could get in and do something about it, maybe support the patients and, at least be forewarned and collect data. And the book we edited called Clinical Risk Management the clinical word was designed to show that this wasn't just about avoiding litigation, although there were chapters on litigation, complaints and all that sort of thing as part of it. So, but from that, it began to broaden out to more concern for clinical issues. But I remember if you went to a conference and talked about this sort of patient safety things as it became in the 90s, you were forever, people who were interested in the clinical issues were forever listening to people saying, but we can't do anything because of litigation and blah, blah, It was ridiculous, but it took a long time to get past that. And
was part of that change then the two kind of seminal reports that came out in the US and in the UK? So To Err is Human in the US and Organisation with a Memory in the UK. Did they sort of change the trajectory of the patient safety movement and put it perhaps more on a systematic kind of approach to, okay, what are we going to do about this problem?
Yes, certainly. I mean, they were hugely influential, and especially the Institute of Medicine report was huge around the world, not just in the United States. And Lucian was flown down to Washington to talk to the media, and President Clinton was involved, I think, all sorts of things. But in our report, Organisation with a Memory, which I was also involved in, was hugely influenced and, led by Liam Donaldson, who really went to the front and made it the sort of signature issue of his time as a chief medical officer. And he was backed at that time by Alan Milburn, who agreed to release it. And I think it's remarkable because I think it was certainly the first official government report in the world about patient safety that said, look, we're harming people. And that report cited our study on the 10%. And I think those studies, the record review studies showing the percentages of people who are harmed, made it clear that this was way beyond a concern with litigation. Perhaps to say litigation is the tip of the iceberg is a bit too far, but it just made it clear that this was a sort of epidemic, if you like.
And of course, your work then on incident reporting and how to do that more systematically has become a sort of very important part of the processes of systematising safety within the UK following those reports. So to what extent were you involved in the kind of creation of the National Reporting and Learning System and the things that sat around it?
Okay, there's several aspects to this. Let's sort of start before the reports were released, because what I worked on, I did do a couple of studies on incident reporting, and what became clear to us quite quickly, we had some really great collaborators in maternity. What we found out very quickly was that only a fraction of incidents were reported. And we worked with a unit where they had a dedicated maternity risk manager. There was a very forward-thinking obstetrician called Richard Beard, who set up systems in his department where people, they really did but even in that, they reported 5-10% of what was going on actually when we checked. They were people who were really serious about it. And there's lots of reasons for that. And at the time, I think, and probably particularly, I don't know about Liam, but if people came from a public health perspective, the idea was, well, if we get people to report things, they'll want to know what's going on. And it was going to be a method of counting as well as stimulating actions and so on. But I think there was certainly a hope that we'd learn all about them. As I say, our studies showed that you only found a fraction of them even with the best reporting systems. So I think we sort of knew fairly early that wasn't really viable. But what I was mainly concerned about, what I thought, I suppose, I put more time into with colleagues, with Sally Adams, with all sorts of group of people who are risk managers, was developing methods of incident analysis. And that was much more the focus of me, was what can you learn from looking at a single incident? I mean, initially we were looking at sort of mostly at near misses or whatever, and thinking and using the ideas of James Reason and the sort of safety science end of it to say, well, okay, what happens if you apply Jim's organizational accident model to healthcare? What does that look like? And more importantly, how do you do that in practice? Not just a theoretical exercise. So we had methods. We had a group of us, Sally and myself, and I think 5 or 6 people who were risk managers, nurses, and most of them had clinical backgrounds and doctors. And we would go back and forth. We developed something and then they'd go back and test it. They'd come back and say, well, this bit worked and this bit didn't. So we developed methods really from the ground about developing initial alarm protocol. It's called then the London Protocol, which we've just, as you may know, just done a second edition. About 25 years too late. But anyway, we keep at it. So the analysis side of it and the learning was always, for me, I think, what I put much more effort into.
That's really interesting. And you've rightly picked me up there. It's not really so much the reporting, it's the analysis. But on that distinction then, do you think the initial systematization of incident reporting and proposed analysis within the NHS achieved its aims or its hoped for expectations?
I think lots of people have very different reflections on this, but let's start with, in the report and organisation with a memory. I was quite surprised, and I think I wasn't the only one on the group, that the report was quite wide-ranging. If you look at it again, it covers lots of different topics and lots of bits about, safety science and culture. But what emerged from it, the principal action, was the creation of an enormous reporting system. And then the National Patient Safety Agency, which was much lamented at that time. We had an organisation which gave a national focus to patient safety, much broader than analysis HSIP, the Incident Analysis Agency, or system analysis, however they think about it, has a very particular remit. But the National Patient Safety Agency had a wider remit, which was to be the sort of national focus. The difficulties they had, it's a long story, but they were completely consumed by the difficulties of creating a massive reporting system which collected millions and millions of incidents, and still does. And that was the national focus to create. And I think we were quite puzzled that although the organisational memory of the support was quite wide, this very particular focus emerged from it. And I think that's partly I think Liam Donaldson was particularly impressed with what could be done with incident reporting. He saw that as the cornerstone of patient safety, and that was what would drive things, and not only nationally but internationally. And I think that was put a huge about. But I mean, his achievement in creating the safety agency and driving it was undoubted. But it was, I'm not talking about Liam now, but patient safety was excessively dominated by incident reporting, and which I think it was clear from people who talked to us from aviation and everywhere else, it was just a component really of what you needed. And we still are, I think, hugely consumed. Because much as I feel that analysing incidents is a very useful thing to do.
As you've mentioned, some of the critics of incident reporting say that it hasn't fulfilled its potential because we imported some parts of the original concept. So looking back and trying to understand how a failure happened and trying to learn from that, but not necessarily the wider intention, which I think is certainly the focus of your incident analysis approach, which is that we should take account of system factors, not just individual active failures. Would you agree with those critics of saying, it's almost like we've cherry-picked bits of the original intention of what incident reporting and analysis could do?
Some of the criticisms are sort of a bit silly when people just say, well, it didn't achieve its potential. You haven't really thought about what it's for. I mean, incident reporting is just collecting data about problems. That's all it is. So, if you collect data about problems in the rail industry or, that in itself is not going to change anything. So when people say incident reporting doesn't change things, well, and the same with the analysis. I don't think the analysis, it's an important step forward, but it's basically a diagnosis or a hypothesis actually about the problems you have. And it's like, people say, oh, it doesn't change anything. It's like saying, well, you gave the patient an MRI scan to find out what was wrong, and then they're not better. Oh, extraordinary. It's not the treatment. And so it's some of the criticisms sort of just silly and naive. But more importantly, I think, is the reflection on the sort of the dominant role it's played. And from what I understand from people who work in aviation and things or other systems, of course, they have a huge amount of routine data. So the reporting system is designed for those kind of weird things that nobody this a funny thing happened, and, you can phone up and talk. And it's a much smaller number. And it's aimed not at the routine errors, if you like, or the small problems that occur on any flight or whatever, they can track, but the kind of weird stuff, that the unexpected, that, it's an additional system to the data, the very sophisticated data they had. And, if you think about a parallel for us, the National Incident Reporting System is full of reports of falls and pressure ulcers and stuff. Now, if you imagine when you've routinely collected falls data in some way, or just had a log that just, did that, then there's an awful lot of stuff that is very, very familiar in there, which either you should collect in a different way or decide not to bother, So we've just used incident reporting a completely different way.
If you were to go back to knowing what you know now, back to those early years and try and advise what they should have done differently, what would you say?
I think for a long time, I don't think just me, I think it's quite extraordinary that we paid so little attention to ordinary measurement of safety events and not treated them more like, we try and measure clinical outcomes, and some of them that crosses over with safety things, but, we just got no routine measures of adverse drug events, or, they've got reports and this and that, but actually sort of thinking, which would have been quite hard to do, obviously, at the time of record review. But for instance, we've never repeated any record reviews in Britain. Safety, there's been a huge number of national safety programs or regional safety programs, which generally we've got no idea whether they did anything. And the whole thing is underpinned by an emphasis on reporting systems where large amounts of money being spent and very little attention to actually measuring things in a sort of systematic, routine way, which is what we normally do in healthcare.
So I guess what you're saying is that we're not applying the same sort of logic as the inquiry that we do about sort of clinical outcomes and processes of what we do every day in the NHS to patient safety issues within the NHS.
Yes. I mean, to think about safety on its own is slightly odd at all in healthcare. And it's obviously one aspect of, in terms of what happens to patients and what's important to patients, is just one of a number of priorities. And I think the justification, I think, for separating it out was originally because it was invisible. As it turned out, enormous numbers of people, bad things were happening to people, not all terribly serious, but, bad enough, and certainly very wasteful. So to give it a label and treat it separately made sense for a while. In a way, perhaps it doesn't now. As you know, we're trying to integrate it much more into a broader conception of, whether you call it quality or value-based healthcare or whatever. I mean, I'm associated with safety. That's just how it is. But I still think it's probably worthwhile because it's almost always the thing that gets lost.
It's the boundary that gets pushed, isn't it, when finance and performance are much more keenly observed, I guess. So I'd like to turn now to another form of learning from failure. So the role of inquiries. And I know that you've been involved in a number of the most significant public inquiries that have shaped patient safety management and also spurred improvement. What do you think the role has been for inquiries in supporting improvements in patient safety, particularly over the last couple of decades?
I can only really give a limited answer to this, because I should say that being involved in inquiries in different ways, but mostly as an advisor, really, in different degrees of formality. I mean, Jim Reason and I did some seminars before the Bristol inquiry about systems thinking to the people on the inquiry that Ian Kennedy asked us to do. I've done reports and, I haven't had a major role or anything. But the inquiries have been led by people who are very, very able and very committed and serious. I mean, throughout, that's the first thing to say. So the inquiries have been very important in the maintaining motivation, drive, prominence to patient safety. It's a huge challenge, but of course, and this is partly the argument for the creation of HSSIB, the Health Safety Investigations Body, was to have something that could act more quickly for an inquiry. Because first, the inquiry, it takes a long time for things to get the scandal to develop, if you like. And then when it develops, there's going to be a decision for an inquiry. That's a massive undertaking. Then you have to find somebody to lead it, who's usually a very able lawyer. But then they have to wrap their heads around, because they're very bright people. Leading an inquiry needs safety systems thinking, and that's not quite the same as lawyers. And the legal team sometimes doesn't grasp that. And then the whole thing takes forever, of course, because they're the giant. And often I think a huge amount of time is spent looking back at what happened. And my main feeling about inquiries is that they normally spend very much time thinking about what to do about it. So rather arrogantly, I remember saying that various people, they sort of kind of tell you what the problems are, And in fact, for Mid Staffordshire, I wrote a short paper saying, from what I've seen, all of the problems at Mid Staffordshire were familiar to people who studied patient safety. Not in the severity, not in the degree, and not in, I'm not saying it was ordinary in the sense, but there was nothing very much that you think, good Lord, I've never seen that before. And therefore the problem is going to be, how to tackle such a strange cultural atmosphere or whatever it might be. And inquiries don't really have people who think much about the intervention side of it, and they don't often have time to do it.
So is there an alternative, do you think, to how we might look at significant or wide, large-scale failings in healthcare?
Yes, well, I suppose the Safety Investigation Body is an answer to that. And when Carl McRae and Carl really wrote about the need for such a body, I think the paper we wrote was more about, from Carl's perspective, he wrote a lot about, he knew the aviation system and he knew why the parallels were important. But actually, the bit I put in was more about the inquiries, I think, and about having a small body that could act much more quickly and could mobilise, not exactly take over from inquiries. But the terms of reference of inquiry, if you're going to have an inquiry, and sometimes I'm sure there's a case for it, for public accountability, all sorts of reasons, but the terms of reference could be set differently. That would be my biggest thing, to start off from something different. And if you think after the Mid Staffordshire inquiry, they did commission the Berwick Review, and that was obviously much smaller and quicker and cheaper and, just a sort of small scale effort. But I think it's a really rather wonderful report, but it's quite short. And it's all about, we've had the inquiry and that's fine, but can we think more about now what we do with what Robert Francis has found, and how we're going to mobilise improvement and innovation from that point? So you could imagine inquiries being set up in a different way, or even have two parallel ones in a way. Perhaps a bit fanciful if you're going to have an inquiry, but you could certainly set off from a different perspective about the future. And when you're interviewing and when you're calling people, and you could be, say, working with relevant organisations from the beginning about the forward plan, not just quizzing them about their failings.
Interesting points there. And some of the things that you've already started to raise, obviously, you know, Charles, that I have an interest in the patient experience of harm. And some of your earliest work was actually on that. And
yes.
In researching for this podcast, I read with interest a paper that I'm actually ashamed to say I've never read before, which was your piece in The Lancet in 1994, entitled "Why Do People Sue Doctors? A Study of Patients and Relatives Taking Legal Action." And that was really a very early exploration, I think, of the reasons why people might seek legal recourse following medical harm. And it was very, it preceded so much of the work that myself and colleagues have done more recently, and was very prescient, I think, in terms of some of the issues that we've come to know more broadly. Do you want to talk a little bit about that work?
There was a paper before that actually called Patient's Experience of Surgical Accident, which was much more directly about the patient experience. It was partly because, I can't remember exactly when, but I was a trustee of Action for Victims of Medical Accidents around that time, in the early days of ABMA. So that was just for people who are listening, at that time it was called Action for Victims of Medical Accidents. And it was an organisation that emerged after the play on the BBC written by a man called Peter Ransley about a woman whose surgery had gone terribly wrong. And at that time, I think it's fair to say that patients and families were treated in a pretty appalling manner, and by organisations, I mean, not by individual people so much. Litigation was obviously a nuisance to an organisation. And I think there was a widespread feeling about that they're just in it for the money.
Do you think it's changed, or
yeah.
Are systems more meeting their needs, or we just made it more complicated with all the range of different things that people are forced to navigate?
Yes, no, I think things are better. I'm just going back to the Lancet paper. The main point of it, and why I called it, "Why Do People Sue Their Doctors?" Because, hey, really, look, okay, the money's part of it. But, of course, as everyone says now, they want an apology, an explanation, and so on. They published the Lancet, obviously, I imagine, I was dealing with a very nice man who actually phoned me and told me it had been accepted. But they had an editorial they ran with it, which was basically a contrary view. And I think saying, well, patients are just in it for their money and the money, that's basically what it said. So it was obviously a live issue. So, well, not in my mind, it wasn't contentious. But I'm saying that now because I don't think you'd ever get that now.
No.
Nowadays, the idea that people they may not get an apology or explanation or sometimes, but the idea that that's reasonable and justified and why wouldn't you, and that's what we'd all want, that's sort of completely commonplace. The systems to achieve it, obviously very, very difficult and complex, but the understanding that that's the right and proper thing to do and humane and all that seems to be understood.
So we may have won the moral argument or moved that forward, but the systemic capacity to enact doing the right thing in these circumstances is a bit more problematic, I guess. Some of your more recent work has started to try to reshape our thinking about what safety means and how we understand safe services, how safe services are. And I'm thinking specifically about the measurement and monitoring framework in particular. Can you describe where this shift in thinking came from and what that framework was trying to do?
We've talked about safety measurement and the lack of attention given to it. And also, the fact that it was not really agreed on what safety was and how you measured it. And of course, one can get very complicated about this and say, well, it's an emerging property and you can't measure it and it's all like in the ether and all this sort of stuff. But you can also think, well, yes, but there's certain sort of harms that one might get to grips with. And there was also a time when mortality or standardized mortality was touted, if you like, as the answer to all safety problems. It was going to be, now I'm not criticizing people, there's plenty of people who understand the pros and cons of standardized mortality, and I worked with them at Imperial, with Paul Alien and people, but it was politically, it was being driven as a sort of marker of everything for a hospital, I mean, in retrospect, seems a completely mad idea, but obviously it can be useful. So the question of whether that, or if not that, then what kind of measures might should we track? Could we use this as a monitor? And the Health Foundation put out a tender to look at this. And Susan Burnett and Jane Carthy and I won the tender. And we started off to look at safety measures. And I had help from people at Imperial. At that time, I had lots of young clinicians around and people to talk to about these sort of things, which was a big help. And what we did was we looked at three things to start with. Jane did a review of how other industries looked at safety indicators, measures. We looked back at how the NHS had done it. And John Benn wrote a chapter about the sort of thinkers in safety, if you like, Jim Reason, and we looked at Eric Holnagel and René Amelberti and say, well, what, from their perspectives, the sort of different angles they take on safety? What do they got to say about measurement? The answer was not much, or not much directly. And I learned a lot from what John wrote, that actually all these people are sort of talking about different things, actually. But they did indicate, that just looking at simple harms were not quite the thing. So I remember looking at all this, I was thinking, well, now what? I think it was clear that just a list of measures in harms might be useful to a degree, but wasn't really going to capture. And I'm not sure. I also had this, I think, these memories of being in meetings where people were looking at organisations and executive board meetings, and non-execs saying, well, are we safe? And I think what I'd come to understand was that there was no consensus about what that question even meant. Is it instant reporting? Some people would say, well, I can tell when I go on a ward whether it's safe or not. I just have a gut feeling. Or, well, if the patients feel safe, that's all that's important. And it's the culture, or any number of answers. All with some validity, but each one of them you're thinking, well, yes, but, And I remember sort of staring at the wall, wondering what to do about this. And I think what came to us, I can't remember exactly how, was rather than we didn't have this, I wouldn't have put it like this at the time, I didn't have the understanding, but a lot of this was coming from what you might call an assurance perspective. If we could just find the right measures, then everything would be fine. And, the tried standardized mortality, and one day there'll be a perfect set of measures that will tell us that we're safe. And now I can see more clearly that this is a sort of complete delusion. And we turned it round and started asking questions. What do we know about our past harm? Were we safe in the past? Are systems reliable? Reliability seems much underrated to me as a basic index of what's going on. And then, of course, are we safe today? Because, you get the sense when you start, if you work in a clinical environment, one thing, but also if you read the theories and stuff, there's a lot about the sort of moment-to-moment stuff. This is part of being safe. It's like this afternoon, what's going on, and then the future. So this, and also then can you put it all together? What do you know from all this? So this gives you sort of 5 questions, and that turned into 5 dimensions. The other thing I knew by that time was that if you wanted anything to have any influence at all in the NHS, you had to be able to put it on one PowerPoint slide. So the report, if you look at it, is like it's 3 big chapters, and then there's a chapter in the middle which is really short. It's basically just, so this is what it is. And then it opens out again about how you actually apply that. And that became nowadays I look back and think, yes, well, that's fine for safety, but really we'd like to integrate it with quality and patient experience and get a framework which actually would possibly value as well. But, you can imagine a fuller framework. But it sounds a bit academic-y, but once you have the core concepts right, whether it's an intensive care unit or an adventure playground, you can ask the same questions and structure your inquiry about safety. And also you can use it to structure the data as well. And you can ask these questions in any clinical environment, and you can come up with answers about how you know And the Health Foundation funded a big program after that, started to put it into practice.
Indeed, which is when I met you for the first time. And a big tip there for anyone working in healthcare: you need to get it on one slide, and then that will ensure successful dissemination.
Of course, there's a big downside to that as well, which is
of course. So I mean, you said some amazing things there, and really interesting things. I was nodding my head about sort of the notion of, I always call it the holy grail measurement. Like, if there's just this one kind of figure that we can say, yes, look, our hospital is 0.8 today and 0.9 tomorrow, or whatever it is. These are the hoped for things, aren't they? People working in management. But I think, in fact, it was within that measurement and monitoring program where I remember you said it was James Reason that is quoted as saying the price of safety is chronic unease. And I just wonder if you think we'll ever get to a point where healthcare systems are able to work with chronic unease, because, as you say, most of them, arguably lots of them, do still work in an assurance model. That's the way that we're almost, as humans, designed to work. Are we safe? Rather than let's keep looking.
There's plenty of people with chronic unease work in the NHS, but it's about inquiry. And I mean, there's obviously day-to-day individuals are absolutely like this, whether you're a clinician on the front line or a manager, you're ducking and weaving and trying to juggle things and trying to be aware of what goes on. And some people are better than others about it. Perhaps it's not built into the processes. And we have this, I'm not so expert now, but I mean, there's also a huge superstructure of governance and so on, which I think rests on the assumption that if we just have enough paper and enough data and enough numbers and, then it'll be safe. And I think some of that's very important, but there's a sort of fantasy behind it that that's enough. And actually, I think safety does emerge partly from knowing the measures. And unlike some people who, might have a vision of safety which is much more fluid and about the process and emergence, I still think that knowing about harms, measuring it and getting a grip of basic understanding of things that are important to patients is very important. And the measurement and monitoring framework is not about abandoning that. It's about saying, look, there's some other things we should think about as well.
So it's holding on to some of the core concepts, but actually framing them within the wider kind of set of safety measurement that we should be doing.
But it's very hard to institutionalise this sort of inquiry in a system that's very, very pressured.
Agreed.
But the sort of are we safe today thing is very, very simple, but it has a lot of consequences once you start thinking like that, because you think, okay, well, if I want to know this, I've either got to have some very clever AI or some, sometimes now staffing data, for instance, maybe almost in real time. So the technology and the data sources can bring us some of this in a sort of IT format. But it's also about, that means I got to allocate a little bit of my day to kind of talking to people and finding out what's going on moment to moment.
So as we draw to the end of our conversation, I want to look to the future of patient safety now. And in your book, I think it was 2016 that you wrote with Renee Alberti, Safer Healthcare, you conclude that considerable efforts have been made, but progress has been slower than originally anticipated, and the earlier optimism has been replaced by a more realistic, longer-term perspective. Do you think that the patient safety movement has lived up to its early energy and promise?
I think it's, in some respects, absolutely, yes. There's a lot of strands here, actually, in this kind of question. In terms of its prominence, the attention given to it, the sort of value for patients, I mean, better than me that there's lots of things still to do, as always are. Have we made progress in the sort of, it's hard to know because we haven't measured it. Probably we've made progress in some areas and not others.
So on that, you've mentioned aviation, and if you will permit me a small indulgence, I'd like to read you a quote from the book by Robert Weirs and Kathleen Sutcliffe, Still Not Safe. And they explore in that book, and I'd recommend anybody listening to this to go up and purchase it. It's a brilliant book. It explains lots of things about the patient safety movement and why it has or hasn't had its effects. But they explore why they think the patient safety movement, as they call it, has stalled. So the quote is, although healthcare loves analogies with the aviation safety story, it obviously ignores other, more useful analogies. Aviation safety was not advanced by pilots working on safety projects, but rather partnerships between subject matter experts, so pilots, mechanics, etc., and safety scientists, so psychologists, engineers, communication scientists. Furthermore, improved air transport safety was not the result of a campaign to eradicate error, but rather of both basic and applied science aimed at understanding and managing complexity in work. And so I felt this was a really nice kind of summary in some ways of the bits that we've taken from other industries, but perhaps that we haven't taken some of, as you say, some of those foundational things around constructing an infrastructure that is, all the way down from regulation and getting some of the basics right, like what are we measuring and how do we know the reliability of our processes and all of those kinds of things. Do you feel like to move forward at this juncture, we perhaps need to look back and revisit some of those foundational elements of the safety infrastructure?
Yes, I very much, Bob Weers, I must say, because personally, he was a wonderful man and a close friend, and I miss him a lot. And we used to have long conversations about all sorts of things. I think the book he wrote with Kathy is gloomy. And I think most people who work in Bob was a long-standing colleague. I think he was particularly gloomy. And I think he particularly sort of suffered in the US from the sort of imposition of standards and naive thinking, about all sorts of things. But I think he's absolutely right. And he pointed out very cogently that I think it was particularly in the 90s, early 2000s, when you went to safety conferences, there were many more people there who were engineers, social scientists. They might be from aviation, they might be from the Navy. It was just a kind of much more that let's learn together, let's think about human factors, the science of it. That was more than just, and gradually that all ebbed. And the safety conferences just became people from healthcare talking amongst each other. And the concern for science went out the window. That's what was. And this echoes as a very wonderful paper written by Richard Cook and I think Dave Woods from a long time ago, where Richard talked about the battle for cancer. And he said that, I think in 1974, President Nixon announced the war on cancer. It was going to be won and fixed in 3 years or something. And it was completely, in retrospect, a kind of mad idea that we'd fix it. And Richard said, the safety movement's been like this, so we're going to fix it. He said, of course, we've made huge progress with cancer, but it's come about through step-by-step, slow application of scientific methods, testing and failing and, grinding along, if you like. And he said, and that's what, he upset a lot of people, Richard, for lots of reasons, but he was absolutely right about that. And I think Bob, too, had that understanding, he always had that vision, and he lamented that Bob Weers, that it was lost. And I do think a lot of the things is just the failure to sort of think it through properly and to treat it, if you like, as a science and engineering problem. All right, it's a socio-technical problem. There's lots of human aspects in it too. And that sort of systematic approach to safety. I've talked about aviation quite a lot, and I don't think there's there are parallels and there aren't. It's a complex thing and you've got to think a lot about the nature of the clinical work you're doing, really, to make the parallels the right parallels. But the sort of seriousness. I remember, Bob, I always think healthcare's at the same time kind of brilliant and innovative and high tech. Simultaneously, the weird thing about it is immensely casual. And Bob Weers once he was telling me one day, he once went to a conference of engineers. And he said he sat there and he was just so impressed by their seriousness and what they were doing. And he said to me, I was sitting there and I thought about a conversation he and I just had. He said, where I'd said how casual healthcare was. And he said the one thing they weren't was casual. They were just doing a job. And I still think, we still rely an awful lot, even now, we want to be inspired. And I always make the think that what the writers say, that if I go to a conference and they want an inspirational speaker, I think what the writers say is that inspiration is for amateurs.
I love that. So we need to get serious about safety. So on that, what's your hope for the next decade of patient safety then? That we get more serious? What do you hope to see?
Well, what I hope, Jane, is that you're going to sort everything out.
Well, I think we could all go home now knowing that won't happen.
You're going to take over and I shall sit back and admire your progress.
Okay, so rather more seriously then, what is your hope for patient safety for the next decade?
I think what Bob Weir says is right, and Bob and Kathy say. More science, more people interested in the underlying ideas, application, more scientific testing, more measurement, treating it much more, if you like, as we would any other clinical problem, really.
Okay, so my final question to you. If you could take all of your experience in patient safety and condense it into one tip for those working to improve safety in healthcare, what would it be? I know you're going to hate this question, but I thought I'll put it to you anyway.
I'd say don't take any notice of people who give you one hot tip. No, I really think it's a disaster.
Good for you, Charles. I'm delighted that you've given that answer, and it's been such a pleasure to talk to you today. I've spoken to you so many times and still I've learnt a lot in our conversation, as always. So it's been a huge pleasure for me. Thank you so much for joining us today.
Well, thank you, Jane. And I always learn a lot from talking to you as well, and it's been a pleasure. Thank you.
Thanks for listening. We hope you have enjoyed this episode and do check out the others in this 6-part series. The series is funded by the National Institute for Health and Care Research and brought to you by the Patient Safety Research Collaboration in Yorkshire and Humber. The views expressed by the guests are their own and do not represent those of the NIHR or the Department of Health and Social Care.